Hi, hello everybody. I'm Dr. Daniel Vorobyov. I'm a medical oncologist and the medical director of Belong. As you know, we are in October month and this is Breast Awareness Month. And as a result of that, I have received a lot of questions from many of you who are interested to understand certain new things happening in breast cancer or with breast cancer, and therefore I'm going to talk to you today about many different aspects. The first question I received was related to triple negative or triple positive patients. What's the difference? Well, let me tell you. So we know that there are certain cancers that in their cell or on their cell, there are receptors for hormones, estrogen and progesterone, as well as HER2, which is human epidermal receptor number 2. When these are present on the cancer cell, the three of them are present, then that is called a triple positive breast cancer. And when they are not present, these three receptors, that is called a triple negative breast cancer. The difference is that they are being treated differently, because on the triple negative, we don't have a specific area or target that treatment can actually block the receptor, while in triple positive, we do. There are three receptors that can be blocked with targeted medication specifically for that instance. As a result of that, the treatments, as I said, they're different, as well as the prognosis of the patients, because triple negative is considered a disease which is a little bit more aggressive or slightly more aggressive than the triple positive disease. So another question I received, it's also related to triple negative disease, and it's about the use of a drug called Avastin or bevacizumab with chemotherapy for these patients. Bevacizumab was, I think, registered around the late 2008 probably, by the FDA. But 2 or 3 years later, it actually was stopped. And why is that? It's because it was found not to be cost beneficial or cost effective for the patients. It has not been removed completely, and although it is not recommended for new patients, but patients that received it continued on the treatment. Recently, there has been a huge study that looked at something like 15 different randomized clinical trials and more than or nearly 6,000 patients. And it was shown that the combination of Avastin plus chemotherapy gives a small, moderate improvement, but it does not benefit the overall survival of the patients. And therefore, although it is still used in Europe, in America, and in other countries around the world, but is not considered to be a first option in the treatment of advanced triple negative breast cancer. An interesting question that I received is regarding the use of the Oncotype test or other similar tests for patients with breast cancer. And actually the question was, is it used for or needs to be done for every single patient with breast cancer. And that's not correct. It should not be done to everyone, but for certain cohorts of patients, for certain group of patients. There are situations where we know that a patient will require treatment, and will require treatment with chemotherapy. For example, a patient with triple-negative disease, or a patient with HER2-positive disease. Those patients, because of the nature of their disease, they require a combination of treatment. But there are patients that they don't need chemotherapy, and we might be able to save them from that and not having the side effects and the costs that there are. Actually, they go together with this treatment. So there are groups of patients which we don't need to treat with chemotherapy. And for that group of patients, or for a group of patients where we are not too sure if they need chemotherapy, then there is value in doing an Oncotype test. And therefore, patients need to be selected for that specific test. So it's not a test available for everybody. It's not a test that gives any value for everybody with breast cancer, but only gives a benefit for certain group of patients. And your oncologist will know if you need it or don't need it to have it. A question was asked regarding the use of adjuvant tamoxifen for longer than 5 years, or what happens after 5 years. Well, there have been recently a few clinical trials that have been done for a long time. One of them, it's called ATAC or ATTACC, and so forth. I'm not going to mention all of them. But in these trials, tamoxifen was actually given for longer than 5 years compared to 5 years. So it was given for 10 years, for example. So there are some subsets of patients that will require tamoxifen to go longer than the planned 5 years. But there is a large group of patients, that will not need it more than the 5 years. What happens after that? Well, nothing happens. You return to no further treatments and return to your normal activities and your normal life as you were before. And you just need to remain under observation and checkups with your doctor. So there is no one rule or one treatment that it's the same for everybody. Treatments depend on every characteristic that you have, and according to that, the doctor can tailor the treatment to your specific situation. Another question was regarding what happens after a year maintenance with anti-HER2 treatment, Herceptin or trastuzumab. So the majority of patients that receive 1 year of trastuzumab actually do not continue with any other treatment. There have been attempts in clinical trials to use, for example, Herceptin for a prolonged period of time, used for 2 years. But actually, the results were not better than the 1 year. And therefore, we do not push for more treatment when it is not necessary. So the majority of the patients will not require any other form of treatment after 1 year, and they should remain under observation and be checked at regular intervals with their oncologist. Another question, a very interesting one, was about clinical trials and when clinical trials are recommended, at what stage, in what situations. Well, clinical trials in breast cancer are actually available, recommended in every aspect of, in every stage of breast cancer. For example, the treatments that we have these days for early breast cancer, the available treatments, are all treatments that came to fruition because early clinical trials performed on patients with recently diagnosed disease, early disease, stage 1, stage 2, and receiving new treatments. And the purpose of that was to get new treatments to delay or to stop the possibility of a recurrence in the future and to reduce the side effects of the existent or current clinical trials. So the same is with advanced breast cancer. We are trying to always get newer drugs, better durations of response, better overall survival, for more patients to happen with lesser side effects. So therefore, the use of clinical trials is strongly recommended if you are attending an institution that is running any clinical trials of this sort. You know, you're most than welcome than asking your doctor or your oncologist about the availability and if you are eligible for any of these clinical trials that they are happening at their institution. You're helping yourself, you're receiving the, probably what's going to be the new standard of care in many instances, and also you're helping others because you are going to confirm the value of new clinical trials for future generations. So it's in your own interest and the interest of other patients coming after you to be involved with clinical trials at any stage of your cancer journey. A question that was asked is related to targeted therapies. Are there any target therapies available for breast cancer? So we need to understand what is targeted therapy. In order to give or have a target therapy, you need to have a target and the therapy that can block it. And once you have the target, for example, estrogen receptor positive, that's a target. So you have a medication which is an anti-estrogen receptor. That's an anti-hormonal medication. For example, like tamoxifen or aromatase inhibitors. So that was the first target therapy for breast cancer already 40 years ago, more or less, and still going well and strong in that regard. And there are many others in newer ones in breast cancer. For example, HER2. We already spoke a little bit about HER2 before, and HER2 is also a target. So the medication that we have these days, anti-HER2, for example, trastuzumab, Herceptin, for example, Perjeta, pertuzumab, they are anti-HER2 targeted therapies. And then we have newer ones like anti-CDK4 and 6 or anti-PIK3, and those are also drugs that can target those receptors. So yes, there are many targeted therapies for breast cancer, and that can help the patient when they have early disease and also when they have more advanced disease. A question that it's very much actual is about the use of immunotherapy for breast cancer. Immunotherapy is usually a type of drug that is given into the body, and what it does, it increases the production of immune cells in the body, usually T cells, and makes the own body to go and kill the cancer cells. So it's not chemotherapy that goes and kills the cancer cells that they are replicating themselves. It increases the T cell production and activates them to go and kill the cancer cells that are in the body. Now, immunotherapy has been shown to be a very active treatment for certain diseases like multiple malignant melanoma or lung cancer and others, but less in breast cancer. And today we can say that there is only one group, one cohort of patients, those with triple negative breast cancer, that they might benefit from the use of immunotherapy. And there are two drugs that are already licensed for that specific treatment, and one of them is pembrolizumab and the other one is atezolizumab. Both of them are available as immunotherapy treatments together with chemotherapy to treat patients with triple negative breast cancer. Patients with other breast cancers are actually not yet susceptible or sensitive to these immunotherapies, and the clinical trials ongoing are trying to decide and design the right combinations for other cancer, breast cancer cohorts. There were a few questions also related to the onset or relationship between COVID-19 and the development of cancer. Not specifically breast cancer, although the question that we have from a patient was about breast cancer. And if we are aware of that. Well, yes, we are aware that there are, in some instances, situations in which patients have been affected by COVID. It could be even asymptomatic, but it has been confirmed by tests. And after a while, the patients suffer a number of immune-related problems. One of them could be the onset of a cancer or even a recurrence of an existent cancer. We have seen some of that and has been reported in the literature, and it seems that COVID and cancer are a little bit of a complex relationship. And it is possible that because of the immune dysregulation that happens in the body following an infection with COVID, causes a dormant cell or causes a slow-growing tumor to actually become more aggressive and more noticeable in a period of time. What is that period of time? We don't have much information at the moment, and there are many research studies ongoing at different places in Europe, in America, looking at this correlation between the onset of COVID-19 and a new cancer or a recurrence of a previously diagnosed cancer. So do we have the last word in this regard? No, we don't have yet. But as with COVID, we are learning a lot, and we have learned a lot in the past 2 years. And I'm sure that new studies will give us more information that we could bring to you so that you are better aware about what is happening. Another question related to COVID-19 was about the presence or the enlargement of axillary lymph nodes after the vaccination. That has been shown to happen in a certain number of patients, and it is more of a reactive inflammatory immune response. It's not related to cancer, and it will not develop into a cancer. And so if you are going to, for example, have a test such as a mammogram, like patients have during October because it's Awareness Month, so try to have it many weeks after you had your last COVID vaccination, because it might be that there will be a relationship between an enlarged lymph node and the COVID vaccination. But once again, there is no evidence whatsoever that this enlargement of lymph nodes will cause or is part of a new cancer. So another question was related to mental health while, at the time that you are diagnosed with breast cancer, as well as if breast cancer or other cancers can be promoted by, for example, stress. So let me answer that one first, and I will say that although we can never be categoric, 100%, we cannot say that, but there is no relationship between stress and the onset of cancer. Yes, it is true that it has been shown that continuous stress can reduce somehow the immunity of the patient, and by the same token, then the patient can become more susceptible to develop a cancer, but has not really been proven. And if that was the situation, well, then we will have that every president of every country and every big CEO, male or female, will be having cancer because of the fact that they are prone to lots of stress and lots of problems that they are dealing with them on a daily basis. And that's not the situation. Regarding mental health and breast cancer, I must say that a large number of people of patients that develop breast cancer, they are exposed to a number of different influences and different sensations. Also, there is anxiety, there is fear, there is the unknown. There are many ways that this mental situation, mental issue, can be actually influenced by the presence of a cancer. Patients find it difficult to cope with, and in many instances they require support, not just support from their family and friends, which is always beneficial and good, but also support from professionals, professionals that can, unbiased, give them understanding, give them treatment when and if necessary, and in that way the patient will cope better with these anxieties and fears. And one of the worst fears is actually, and more common, it's actually the fear of a recurrence. Something, yes, okay, I'm going to be fine now because I'm on treatment, but what when I finish my treatment? What's going to happen to me? And what will I be around in a year or in 10 years' time? And that fear of recurrence is something that is very common in patients with all types of cancer, and that also needs to be attended to. So yes, I will strongly recommend support from families and friends, but also do not hesitate and consider support from a person, from a doctor, a psychiatrist or a psychologist that can guide you better how to deal with this situation. So I thank you all for submitting all your questions and your queries, and please continue doing so. Thank you once again, wishing you a good, healthy time, and Belong is here to support you and to help you and to guide you during your cancer journey.